Thanks for coming out to our program tonight. My name is Time Smiley. I'm an administrative assistant at the JES, and I have a couple of things to go over before we start tonight's presentation. First, some housekeeping. I'll tell you about upcoming JES events, and then I'll introduce today's presenter. For some housekeeping, we do have a Q&A section after the presentation. Just make sure to raise your hand, try to speak up and speak clearly, and we prefer questions, not stories, so try to keep it concise. And then additionally, if you need any assistance during the event, please just ask me or Brian, who's back there. We'll be happy to help you. Alrighty, and for our upcoming events, next Monday at 6 p.m., Sarah McCall will be presenting a talk at the Lincoln Community Center Library called Exploring the Role of Public Libraries in Addressing the Loneliness Crisis. And then she will be again talking Wednesday at 6 p.m. At Lincoln Community Center Library with the same topic. So if you missed the first one, you can always come to the second one. And then finally, on Thursday at 7 p.m., Dr. Paris Baker will be speaking about cognitive conception when men become fathers at Erie, at ECAT, so here. And then finally, sorry, let me pull up my phone. I would like to introduce our presenter tonight, Dr. Joshua Tuck. So Dr. Tuck is an orthopedic sports medicine surgeon practicing at LECOM Health, Orthopedics and Pain Management. He's a graduate of the University of New England College of Osteopathic Medicine, where he attained his doctorate in 2004. He also obtained a Master of Science in the Medical Education from Lake Erie College and a Master of Business Administration degree from Eisenberg School of Management at the University of Massachusetts Amherst in 2021. He also recently completed a Master of Science in Healthcare Delivery Science from Dartmouth College. He's a fellow of the American Osteopathic Academy of Orthopedics, the American Academy of Orthopedic Surgeons, and the Arthroscopy Association of North America. He currently serves on the board of directors. He currently serves on the board of directors for the American Osteopathic Academy of Orthopedics. He has multiple publications in various journals and textbooks and is assistant clinical professor of surgery and orthopedics at LECOM. If we could get Dr. Tuck a warm JES welcome.
Thank you. Good evening.
It would be nice if I could.
This microphone. Thank you. Can everybody hear me okay? So, as fate would have it, I developed a laryngitis probably like 4 hours ago. And so it's perfect timing for this. So this is going to be painful for the group, but I'll try to get through this quickly and clear my throat minimally. But I'm excited to be here tonight to present something that I'm very passionate about, ACL surgery, ACL reconstruction. I've been doing this now for 13 years since fellowship in my 13th year of practice. And I can tell you that I do not do ACL reconstructive surgery the same way that I did in my fellowship or in my first 5 years of practice. It has changed every few years. I've gone from one graft type to another, to a third, and now to a restorative procedure. And like everything in medicine and healthcare, it continues to evolve. And so I'm excited to be here to talk to you a little bit about that evolution. And I'll talk a little bit about the history of the ACL reconstruction, the problem, how it presents, what we can do about it, certain preventive measures that have shown some promise, and where we are in 2025 ACL surgery. So without further ado, so again, I'm going to talk about the ACL, its anatomy, its function, how it presents in terms of injury, why it doesn't heal on its own traditionally, what we've done in the past, how we have succeeded and how we have failed surgically, and where we are. So Talk about the function, the structure and function of the ACL, diagnosis, recognition of injury, treatment, traditional surgical options, where we are, and also a little bit about the future. So the ACL anatomy. The ACL is obviously located within the knee joint, traverses the femur to the tibia. As the name implies, cruciate crosses the posterior cruciate ligament, which is just behind it, and they form a cross, or what's called a 4-bar linkage, that really prevents translation or movement of the tibia in relation to the femur. You do not need a functioning ACL to walk. In fact, there are multiple stories. Anybody who's a sports fan can probably name a few athletes who had a fairly successful career in the absence of an ACL. So you can do it. The issue is that the knee, in the absence of an ACL, goes through considerable wear, and the rate of arthritis is accelerated typically in the absence of an ACL, and there are other collateral injuries like to the meniscus that I'll talk about in the absence of an ACL. So again, nobody dies from an ACL tear, okay? But certainly an ACL tear can cause significant disability in the knee, subjective instability with traversing uneven surfaces, and further injury and accelerated arthritis. So that's why we make such a big deal about ACL injury. PCL, not that this lecture is about PCL, but I should mention the posterior cruciate ligament is a different structure entirely. Although they're sister structures and they're adjacent to one another, the PCL in the back of the knee actually does have the inherent ability to heal itself. It has a better blood supply, and traditionally, the PCL is treated non-operatively for the majority of the injuries, even high-grade PCL injuries. That's a different lecture. The ACL, however, does not have the ability to heal itself, and I'll talk about why that is, okay? So the size and composition, it measures approximately 33 to about 40 millimeters, depending on the height of the patient. About 11 millimeters in width at its widest point, and that changes by the gender and height of the patient. There are two bundles of the anterior cruciate ligament, the anteromedial and the posterolateral bundle. And again, the primary function is to prevent excessive forward translation of the tibia in relation to the femur. Whenever you flex and extend the knee, there's a combination of roll and glide that has to occur in that complex joint, okay? It used to be just called a hinge joint. There's actually a lot more going on in the knee. There's a little bit of rotation and terminal extension, and there's other things that are required for normal gait. So the anteromedial and the posterolateral bundle, the two major bundles of the anterior cruciate ligament. The anteromedial bundle is typically tight with the knee in flexion, and the posterolateral bundle is typically tight with the knee in terminal extension. And they work in concert with one another. And the posterolateral bundle is more involved in the rotatory control, the rotational control of the tibia in relation to the femur, where the anteromedial bundle is truly more involved with the anterior translation of the tibia in relation to the femur, the anterior motion, or the forward motion of the tibia in relation to the femur, I should say. And then there are biomechanical properties of the ACL that make the structure unique. It has a high tensile load, and it can accept 4 to 5 times your body weight at any one time. So it's a pretty impressive structure. And I would tell you that grafts over the years have evolved to try to mimic that structure, but even the best of grafts don't quite get there. So again, excuse me, anterior stability, we've talked about rotational control, particularly through the posterolateral bundle. Proprioception, I'm going to come back to because that's exceedingly important. And dynamic function, cutting, pivoting, twisting, bending, climbing, jumping. The check rein component of the ACL shines in those motions. It's not inline walking or even inline running. It's movement in the coronal plane where you need the ACL to function appropriately, lest you have too much motion through the tibia in relation to the femur. Proprioception is a mechanoreceptive function. Now, what do I mean by that? It's a difficult thing to describe, but proprioception is a structure's knowledge of itself in space, okay? And that sounds a little hokey, but what it is a structure has mechanical receptors in it. And those mechanical receptors are giving constant feedback back to the brain and spinal cord about where that structure is in space so that it can adjust in real time to every demand, okay? And that is called proprioception as a concept based on mechanoreceptors. And you have them everywhere. You have them in bones, joints, cartilage, and you certainly have them in the anterior cruciate ligament. When we reconstruct an anterior cruciate ligament, which has been the gold standard for decades, we are not able to reproduce that proprioceptive property. So whether I take your own tissue and make a graft out of it, and I'll talk all about this ad nauseum, or I take tissue from the freezer and turn it into a graft, I'm never going to get back the mechanoreceptors that you were born with, okay? And so some mechanoreceptor properties can be returned to a harvest graft from your body, but not the same as the native tissue, which is why we talk about repairing it now. So again, I mentioned this 4-bar linkage system. ACL and PCL cross each other, cruciate, hence the name. The idea of the 4-bar linkage is that there's a link between the femur and the tibia, crossing with the ACL and PCL, and that again, these work in concert in both forward and backward translation of the tibia and rotation. And I keep repeating myself because there is a point to this. So the majority of injuries to the anterior cruciate ligament, and understand too, when you injure the anterior cruciate ligament, there are grades of injury. So there can be sprains, first, second, third class sprain. There can be partial tears or single bundle tears that can occur, and there can be full thickness anterior cruciate ligament tears, and they present differently. And that's the importance of a good physical exam and obviously MRI. About 70% of anterior cruciate ligament tears are actually non-contact tears, okay? And so the majority of the time, having done sideline medical coverage for years on multiple sports, I could tell you what would give me the greatest cringe would be seeing an athlete on his or her own take a quick pivot, turn for the ball, move just right with nobody else around them, and they hit the deck, grabbing their knee. And that is basically an ACL tear until proven otherwise, okay? And so the other thing that we used to say in sports, and I think it still holds true, is that in the female athlete, and I'll get to this too, a female athlete with a buckling event through her knee and immediate swelling, or what we call a fusion, fluid in the joint, is an ACL tear until proven otherwise. And so that's how common these are, okay? But again, the majority are not the impact force that you would expect, striking another player, hitting a surface. They are in fact non-contact pivot injuries, okay? The high-risk demographic is the female athlete. And there have been countless, I published a paper on the female athlete ACL tear. We all have our own theory why the female athlete is at a much greater risk of ACL tear than their male counterpart, and it is 2 to 8 times higher. It is a scourge of the female athlete, particularly the young female athlete. And there are hormonal influences. There are notch width influences. The notch on the femur is where the ACL and PCL live. They tend to have a more narrow notch than their male counterparts, which appears to be independent of their height and weight. So it's a true anatomic difference. Hormonal influences, there are estrogen receptors in the ACL, and there is a correlation between a woman's menstrual cycle and rate of injury. I wrote a paper on the middle genicular artery, which is the chief blood supply to the ACL. It is actually narrower and shorter than the male, independent of height and weight. So there are a lot of factors that might contribute to why females are more likely to tear their ACL than their male. It's not our topic tonight, but it's a fascinating topic with countless papers in my world written about it. So the annual incidence of ACL tear, and that's full rupture, about 200,000 a year across the board. Again, women 2 to 8 times more likely than men. 15 to 25 years old is the big age where most of these are occurring. Certainly that is, I've done ACL reconstruction on 70-year-olds, but between 15 and 25 is the highest spike of incidence. What I'm going to be talking about, the BEAR, the ACL restoration procedure, actually came out of Boston Children's Hospital from a research group that was looking for a better answer for kids who tore their ACL under the age of 15. We're seeing an increased incidence of kids tearing their ACLs at 10, 12, 13 years old. That is horrible for a lot of reasons. And I could go on and on for days. I could bore you people to tears, but there are a lot of reasons why this is happening to younger kids, and it's got to do with greater American demands on our youth in terms of sport, different conversation, but that's where the BEAR came from. It came from the need to come up with something better than a reconstruction in a 12-year-old. And then, of course, the healthcare burden, there's significant costs associated with this annually in the neighborhood of $2 billion plus a year. So, the pathoanatomy of ACL injury, complete tears, again, 70% of the time occur proximally. In other words, they occur from the femur side or the origin of the ACL. Again, the ACL traverses from the medial aspect of the lateral femoral condyle down to the tibial base, and the majority of those tears come off the femur, and the rest come off the mid-substance, with relatively few coming off the tibia. Why is that important? Again, when I talk about restoring the ACL, that matters. Vascular, again, poor blood supply to the ACL, the middle genicular artery. The cellular response, when we tear a ligament or tendon elsewhere in our body, it typically has the propensity to heal itself. The reason for that is at the time of the injury, the body goes through an inflammatory response, which we know is important and why we don't recommend routine use of anti-inflammatories at early acute injury, because you need that inflammatory response because it recruits a host of cells that are important to come in and do their job, to start to break down and repair tissue, lay down a blood clot, replace it with fibrin, and eventually the tissue that was injured. That does not happen in the anterior cruciate ligament. And the reason that doesn't happen is the anterior cruciate ligament is what's called intra-articular but extra-synovial. It's a unique structure. Now, what does that mean? Intra-articular means that the ligament lives in the environment of the joint. It's truly inside the joint, but is extra-synovial. In other words, it is surrounded by a substance called a ligamentum mucosum, okay? And that substance gives it a continuity to the external environment as well. When it ruptures, that structure gets injured, and it is bathed in a synovial fluid, which is the normal lubricant of your knee joint. In fact, all of your synovial joints in your body have a synovial fluid. Helps to lubricate the joint. It's a beautiful substance. It's better than any oil you ever saw. The problem with that substance is when the ACL is swimming in it, it cannot get that inflammatory blood response. And it can't get those cells to come in, and those interleukins and the metal metalloproteinases and all the things that you need for a healing response doesn't happen for the ACL. It does happen for the PCL in its backyard, though. So that's the difference between the ACL and PCL, and why one tends to heal and the other one does not. The other thing to note is that when an ACL tears, very oftentimes it's not in isolation. There's something else in the knee that goes at the same time. It is typically the posterior horn of the lateral meniscus that typically goes. So the meniscus is the structure on the outside of the knee, and I'll show you all this. The two semicircular structures that look like boomerangs inside your knee between the femur and the tibia, they provide congruency to the joint, shock absorption to the joint. Typically one of those, and it's usually the one on the outside of the knee that tears acutely, okay? Chronically, so somebody with a chronic ACL deficient knee will have a medial meniscus tear as well, and that's because those forces that the ACL was supposed to be taking care of, i.e. the translation of the tibia in relation to the femur, gets transferred to the posterior horn of the medial meniscus, which is a structure back here, a job it was never intended to do. And so that eventually tears as well. So that's the collateral injuries that we talk about associated with ACL tear. Additionally, chronic ACL tears, in addition to having a posterior horn medial meniscus tear, they will often have significant cartilage loss because the knee was not designed to take that constant shear force that the knee is going through with every motion in the absence of a functioning ACL. So again, the natural history of an ACL injury, I already kind of talked about this. There is an acute inflammatory phase. They hear a pop, they go down, the knee hurts, they don't want to bear weight on it, and within 24 hours it swells. And I would tell you the majority of them swell within the first few minutes, right? There's a significant bleeding response associated with that, and it's a hemarthrosis, blood in the joint, right? Within a couple of hours, there's a subacute phase where they have a decreased range of motion. The body splints itself to injury, so typically they can't move the knee because it's trying to heal itself in response to the injury. And then the chronic instability occurs weeks, months, years later. You see somebody, I just saw somebody who's 6 years, he hasn't had a functioning ACL, and they get this chronic instability where they're okay on even surfaces, and they go weeks and even months without a problem, but they step off the curb wrong and they hit the deck. And it's because the knee does not have the inherent stability for certain subtle motions to traverse an uneven world. So the physical exam starts with initial presentation. You get the patient's history, determine if the history is consistent with a possible ACL disruption. Acutely, if you see the patient within the first few days or weeks of injury, they may very well have a hemarthrosis, an effusion, fluid in the joint. They just call it water on the knee. They'll have a decreased range of motion, an antalgic or painful gait pattern when they walk into your office. There are several tests that we can do. The anterior drawer is the classic test where you bend the knee to 90 degrees, the patient's sitting on the table, and you're simply pulling the knee towards yourself as the examiner, back and forth. And if there's greater translation in the tibia in relation to the contralateral side, then it's consistent with a possible tear. The problem with that test is you can get a false negative because the hamstring fires, pulls the tibia back, and it feels like it's stable when it's not. The Lachman test is actually more sensitive, and it's the one we hang our hat on in the office. A patient's laying supine, flat on their back. It's a 20 to 30 degree flexion through the knee, and you're providing a translation force through the tibia while you hold the femur firm with your other hand, and you feel both the translation of the tibia in relation to the femur and the end point. And then we grade that. So we have a language to that. So a Lachman 1, 2, or 3 is 5 millimeters, 10 millimeters, greater than 10 millimeters in translation compared to the other side. And then an A is a firm endpoint and a B is a soft endpoint. So I could say to another orthopedic surgeon, I got a so-and-so with a Lachman 2B, and I just told him or her that that is an unstable ACL with a soft endpoint, okay? So that is an 85% sensitive, 95% specific test in the right hands without an MRI. The pivot shift test is an exceedingly important test, but we typically do it with the patients asleep. So we've already brought them to surgery. We've already made the diagnosis. The problem with pivot shift is it's very hard to do it on somebody who's awake and active because the muscles don't really allow us to do it. But essentially, we rotate the knee through flexion, bring it into extension, and what happens is it clunks into extension because the ACL isn't there as a check rein, and the hamstring fires and pulls the knee back. It's a measure of rotational control as opposed to just translational control through the knee, okay? So that might get a little muddy, but just suffice to say, the Lachman in the anterior drawer done when you're awake. We've brought you to surgery and you're asleep. Now I do a pivot shift on you to see if the posterolateral bundle is involved. All right. Everybody gets x-rays first. Americans hate that too. They go, why do I get an x-ray? I know I need an MRI. Yeah, maybe. But the reality is that we pick up a lot of things on x-ray that MRI actually doesn't pick up or is less clear on MRI, okay? There are certain findings on an x-ray. A second fracture is a classic finding where there's an avulsion, a little chip of bone taken off the lateral tibial plateau, and that's consistent with another structure that oftentimes pulls off when the anterior cruciate ligament pulls off. It's called the anterolateral ligament. Again, a different conversation. But there are findings on plain x-ray that help us deduce an ACL tear without the MRI. Now, with that said, in 2025 American medicine, we're getting the MRI too. You get the MRI. Ultrasound is also, I should say, ultrasound. I do not use it in my practice, but it is a very strong utility. And in the right hands, there's pretty good success with diagnosing ACL tears with ultrasound. That is an emerging world. And with American health dollars going away, ultrasound is going to get more popular because it's very cheap. MRI still is one of the most sensitive and specific ways for us to evaluate, and it's the routine thing done if we think you have an ACL tear. And you can see here that we have sagittal views. These are two T2 weighted sagittal views of the knee, so they're looking at the knee from the side. And obviously, this is the femur on the top, the tibia on the bottom, and this structure right here is the anterior cruciate ligament, okay? And that's intact on that patient, and you can see this next specimen where it is clearly disrupted, okay? This is a coronal view looking at the front of the knee, and this anterior cruciate ligament, the arrow pointing out right here, is disrupted, okay? And then over here, I like to point this out, and I teach the residents this, and when I write questions for the board exam, I always include this image. This is a femoral and tibial bone edema pattern or bone bruising pattern that is consistent with ACL tear. And so, again, an ACL surgeon, you can show this image to without showing them where the ACL is because this is the wrong cut. It's not at the level of the ACL. But they could see that and say, oh, yeah, that's an ACL tear because that is the pivot mechanism of injury required, that pivot that occurs through the knee that blows the ACL, and it leaves behind these bone bruise patterns that are pathognomonic of the injury. The diagnostic arthroscopy, however, is the gold standard. In other words, nothing better in medicine today. You put a scope in the knee and you confirm within a minute with a probe that the ACL is in fact torn. I cannot tell you how many times an MRI has been inconclusive, but the physical exam alone and the patient's history was enough for me to bring him or her to surgery, and we confirmed it intraoperatively. So MRI is good, but it's not perfect like many of us believe. So what's some non-surgical management? For ACL tears, certainly not every ACL needs to be reconstructed or fixed. Okay, I think in certain patients, low demand patients, patients with multiple medical comorbidities, reasons not to operate, you can absolutely treat the ACL non-operatively. And there are plenty of stories. There are a few football players that come to mind, running backs, postseason, had to stay in the game, had to keep going. You can brace people, you can inject people, you can get them through. Okay. Whether or not that's good medicine is another conversation, but you can get them through. So not everybody needs it. And there are things like physical therapy, anti-inflammatory medications after the acute phase of the injury, bracing, functional bracing, sport-specific bracing. There are things you can do to get people by. So I don't want you to leave here thinking that every ACL needs surgery necessarily. Depends on the patient, depends on a number of factors, demands, lifestyle, etc. So a little bit about the history of ACL treatment options. Pardon me one second. Watch how awkward this is. Any questions so far? So the history of ACL treatment is interesting. You know, we've been working on this for over 100 years. It's not a new problem. And what I think is fascinating is that when ACL tears really started to share some limelight in orthopedic surgery, which itself is a relatively new discipline. That's a side note. The first ACL interventions were attempted repairs, okay? And they were open procedures. And they went in and they did suture end-to-end repairs and hoped for the best. And they didn't do so well. But there wasn't a real strong understanding as to why that was, because tendons elsewhere in the body and ligaments elsewhere in the body, you could do an end-to-end repair and get some good results, but not with this one. So you fast forward to the 60s and 70s, and now arthroscopy started to make a major impact in American medicine. It had been popular in Germany and Japan years earlier, in France, but it made a big impact in the United States. And then in the 1980s and 90s, arthroscopy really blew up, and the instrumentation improved so much that arthroscopy wasn't just a diagnostic modality, but you could actually perform surgery through a scope. And it's interesting, another side note, that the American Academy of Surgeons laughed arthroscopy out of the room in one of their meetings in the 1960s, late 1960s, because they thought it was nothing more than a parlor trick. They never thought it would take. And so, lo and behold, 1980s, 1990s, it blew up, and there were new developments in ACL surgery. And there was this thought in the literature and a massive movement that, hey, the ACL just can't heal. We've tried it in the past. We've used various augments. We've used various tissue constructs and non-graft options, and it fails miserably, so it has to be reconstructed. So that became the mantra for all of us, including myself when I trained in the early 2000s, is that you can't repair an ACL. You just got to reconstruct it. And so all of the literature focused on how to reconstruct it. And it came down to tunnel position, and it came down to graft type, allograft versus autograft, okay? So patient's own tissue, autograft, allograft is donated tissue. Human tissue, bovine-derived tissue, right? Porcine tissue. The use of synthetics. So all of these things have had a role, and they've had varying degrees of success. Well, you know, the last 15 years, 10 to 15 years, our techniques have been so well refined by the literature that any surgeon who does ACL surgery knows where to put it now. We're all pretty confident on where to put it. Even though you might do it differently than she does, than he does, we all know where it needs to go. We all agree on that, finally, right? But we still don't agree on graft type. And we still don't agree on timing of surgery, and we still don't agree on how to tension it or how to fixate it to the bone even. And so my point is across the board, no matter your reconstruction technique, how you were trained, or what Kool-Aid you drink as a surgeon, the success rate for ACLs was exceedingly good. It was over 95% across the board for almost all comers. Excellent surgery, right? So we'd be arguing over the last 5%. And so keep that in mind as we go forward to now, so anatomic reconstructions is what I was just talking about, to these modern repair techniques where we're really trying to get that last 5%, get it to 99% or better, right? Because there is still a 5% to 7%, up to 10%, depending on who you read, risk of re-rupture, even in the best of hands. And so we're always looking for a better way, and that's why some of these restoration techniques came to be. So again, I won't beat this up, but you can see the evolution of ACL surgery is 120 plus years in the making. And in the 2020s, the biological approaches that I'm going to be talking about here, that's a big buildup, but I'm going to be talking about here, really took off. So the Bear is a relatively new procedure that, like I said, came out of Boston. It is FDA approved. This is not experimental. But it has managed to address many of these issues that we had with traditional reconstruction. So traditional reconstruction, again, we're replacing the damaged ACL. So if I went to your knee and it was a high-grade partial tear or a complete tear, I simply debride the remaining tissue. I take off any stump or remaining ACL that's in there, and I put my new tissue in there. I drill a tunnel through the femur and through the tibia, and there's various ways to do that, inside out, outside in, etc. And they take a graft either from your own body, so that's bone, tendon, bone from the front of the knee, or it's hamstring from the back of the leg, or it's quadriceps tendon from the top of the patella. So it depends on where you trained and what you believe in and what works in your hands. And I have done all three. I started bone, tendon, bone. I went to hamstrings for years, and I went to quadriceps about 5 years ago. So you take that tissue, you bring it to the back table, you cut it to size, you put it on tension, you prepare it, and then you bring it into the knee, you shuttle it into the knee, and you fix it with either screws or buttons or a combination thereof, okay? Staples, transfixing pins, it's all been tried. But that's how you reconstruct an anterior cruciate ligament. There's usually a period of partial weight bearing after, or non-weight bearing. There's a special brace. There may be a continuous passive motion machine you go home with, and it's about a 6 to 9 month recovery, up to a year, depending on sport. Modern repair techniques, a little different. With those, we're trying to preserve what tissue you have in there. Now, you have to meet certain criteria. The tissue cannot be destroyed. So when we go into a knee and we're considering trying to repair it instead of reconstruct it, one of the first things we do is free the tissue from the underlying scar. We free it from the PCL. And then I put a couple of sutures in it, and I usually pass those with a suture passing device, and then I pull on it. And I'm trying to convince myself that it'll hold suture. If the suture just pulls right out, I pivot to the reconstruction, which is why patients are consented for both preoperatively. Insurance companies love that. So again, autograft and allograft reconstruction, I won't spend too much time on this. There are pros and cons of both, and that's a weekend conference argument. Autograft, again, is taking your own tissue from somewhere else in your body and making it into an ACL. Allograft is donated human tissue, okay? Autograft has a lot of perks. It's using your own tissue, so there's no risk of disease transmission. There is a decreased risk of re-rupture using your own tissue under the age of 35 to 40, depending on who you read, okay? That's why under the age of 35 with my patients, I usually insist on them using their own tissue. Between 35 and 40 is a gray zone. We have a conversation. Over 40, I usually recommend patients use allograft. The reason allograft has a role is because you don't have the comorbidity of giving up tissue from somewhere else in your body, right? It's kind of nice. It's also the only time in your life you get to upgrade your body, because most tissues that are donated are under the age of 40 from the donor, okay? So there are reasons to use allograft tissue. Most of it is either irradiated or chemically treated so that the risk of disease transmission is exceedingly low. And people do very well with that. So again, it's very patient specific. Autograft versus allograft. I use both. Since a lot of my patients are under the age of 40, I tend to use more autograft. And again, I've been taking the quadriceps tendon, turning that into an ACL and giving it back to them. Primary ACL repair, again, an emerging technique that I'm going to get to here eventually. It is only suitable for those tears that occur, like I said, 70% of the time from the femur, because you need enough length in that tendon for enough suture passes to pull it back up to the femur where it belongs. And I'm going to show you all that, okay? The tissue quality has to be appropriate to hold suture, like I said. And there are other issues with the patient. So ideally, the patient's a non-smoker. They're not obese. And the injury is within 6 to 8, 10 weeks old. So initially, it was 4 to 6 weeks in the research for an ACL restoration, or a Bear specifically. Now they're saying that probably 3 to 4 months is okay too, but it's not ideal for somebody who's a year, 2 years out from their ACL tear. And then hybrid and augmentation techniques, I got to mention this too. So this is ever evolving. And I did my first Bear here in town just over a year ago. And I'm already doing them different than I did them a year ago. So now we're doing something called an internal brace. which is a very strong high tensile suture that goes adjacent to the repair that goes from femur to tibia. And just as the name implies, it is an internal brace mechanism to prevent re-injury to the repair, to allow the repair to heal. The idea being that if there was a translation force through the tibia during the healing phase, that brace would prevent it from translating to the healing tissue. And so there's enough good data on that I have drank that Kool-Aid, and I'm doing internal braces on all of my restorations. And as it was originally described, the bear described an internal brace, so that's not new or unique. What is unique is that there are many options and techniques described where it's just an internal brace that's put in, or it's an ACL repair that's performed all suture style with something else injected into the tissue to help it heal with an adjacent internal brace, okay? And now what are those things? Well, everybody's heard about PRP, right? And mesenchymal stem cells and all this other hot stuff that's out there. A lot of this isn't covered by insurance, but it is a hot market and there is a role for it. But suffice to say, there's a number of things that you can do to the ACL to try to promote healing and do a primary repair. So the pendulum has really shifted back towards we try to repair these if we can, because we know that if they're repaired and repaired well and they heal, they get to keep the proprioception, those mechanoreceptor forces. They don't have any comorbidity of giving up tissue elsewhere, and it's bone sparing. We don't have to drill big tunnels in the femur or the tibia. And you don't burn any bridges. So I won't spend too much time on this. These are the chief autograft options for anterior cruciate ligament reconstruction. Patella tendon graft for years was called the, quote, gold standard. There's bone at both ends. You take a wedge of bone from the patella, you take the middle third of the patella tendon, and a wedge of bone from where it inserts on the tibial tubercle, okay? And so you have a bone, tendon, bone, a BTB, okay? And that helps to promote bone-to-bone healing, usually screw fixation on both sides, either metal or composite, biocomposite. Excellent healing. All the pro athletes prefer BTB. The older folks that do orthopedic sports surgery still love BTB. They hang their hat on it. It's a great graft. The problem with BTB is that there's a 40% risk of knee pain to the front of the knee for the rest of your life, because what happens is it leaves a defect in the front of your kneecap, and there are nerves that traverse that area, and once they're disturbed, you can have chronic pain. So that's a big deal. The other issue is that patella fracture, the risk of fracturing the kneecap, goes up significantly because we're taking bone from there. So what else? Well, then hamstring became popular. You can take the semitendinosus and the semimembranosus, the gracilis tendon. You could take these tendons, turn them into an anterior cruciate ligament by quadrupling them on themselves, okay? They do have the propensity to grow back a little bit. Problem with the hamstring tendon graft is it tends to stretch out even after time zero. So even after you place it, it can stretch out a little bit and cause a little more laxity in the reconstructed knee than you would like, because that's why you're reconstructing the knee, to get rid of it. So hamstring worked well for a lot of years, and it is still used widely. It's still a great graft, but it's not without its issues. And then quadriceps I used to just use for revision procedures, and then became a good primary option because it's a very thick graft. We have more control over the length and thickness of the graft. It doesn't have the same soft tissue creep characteristics or stretch characteristics that hamstring has. So all different grafts, all different pros and cons. Again, depends on where you trained and what you believe in. If you got 10 ACL surgeons in this room, they wouldn't agree on any of this stuff, including what graft type to use. But typically, for younger patients under the age of 35 to 40, we prefer autograft, any one of these, to allograft. Over 40, it's typically allograft. So that is a quadrupled hamstring up top here. That over there to the right is a quadriceps, but it's a double bundle quadriceps, which I didn't even get into. That's a whole other thing. That's a bone, tendon, bone down below there. And that's a gracilis graft on the end. So that's a thin graft, not routinely used alone in ACL reconstruction, but it can augment your graft tissue. Very briefly, double bundle ACL reconstruction. I only mention it to this room because it came out of Pittsburgh, Pennsylvania, right? It came out of UPMC by a genius of a surgeon named Freddie Fu, who just passed away a couple of years ago, unfortunately. He was an amazing surgeon. He was a pioneer in ACL reconstruction. He's the one that taught us the anatomy, the anteromedial and posterolateral bundles of the ACL, and he promoted a reconstruction technique drilling 2 tunnels instead of just 1 through the femur to more closely reapproximate the native anatomy. Again, not the topic of tonight, but suffice to say there are actually double bundle options for reconstruction, which started right in Pittsburgh. So allograft options. Again, there's no donor site morbidity. It's a chance to upgrade, smaller incisions, reduce surgical trauma, decrease surgical time, increase surgical cost. But they do have a higher failure rate under the age of 35 to 40. And everything you can imagine, you can order whatever tissue you want, essentially. But when I use allograft, I also tend to use quadriceps. All right, so again, I mentioned this a little bit earlier, repair versus reconstruction. The traditional perspective was the ACL won't repair, can't heal it. Out of luck, don't try it, just reconstruct it. And that's what we did. We drilled tunnels and reconstructed, and when those failed, which wasn't often, but when they fail, now you have a big issue. Now you have two tunnels in the femur and the tibia. They're often enlarged. Now you're out of real estate, like we say. And so oftentimes you have to go back in and take out your screws, take out your pins, your buttons, take out whatever remaining tissue failed on you, and then bone graft the femur and the tibia, bring them back in 4 to 6 months, hopefully your graft incorporated, so that you have space now to drill new tunnels through your graft sites. And so the point is it becomes much more difficult, and the results, the outcomes, as you can imagine, drop off significantly vice a primary reconstruction. So I do a lot of revisions from the community and elsewhere. It's not ideal. It's not ideal. The idea now is that if we can avoid all of that, if we can try to somehow preserve the tissue that you have in there, if we can figure out a way to get that tissue fixed and help promote it to heal, give it the right environment for the body to do what it wants to do. The body has the inherent ability to heal itself. The idea of the bear and other procedures that augment the tissue is to help the body along to do its job. You retain your ACL, you retain the mechanoreceptors, the proprioception, and you're not getting big time tunnels. We do have to drill small tunnels in the femur and tibia to place the internal brace and to fix the defect in the ACL, but they are small little drill tunnels. They're not large 10, 11, 12 millimeter tunnels like you need for a graft. So again, the primary option, this is the way I approach ACLs in my office in 2025 in my practice, okay? So when anybody walks in the room, the first thing I'm trying to think about is a primary repair for them, because I'm convinced, as are many of us, that if I could get a primary repair on your ACL, it's for the best. Again, you have to meet a number of criteria. The injury has to meet a number of criteria. I would tell you the majority of patients that I see in my practice are actually not candidates for a bear or a repair because of a number of factors, okay? But I'm always looking to do that first if I can, because I believe, like many of us, that that's the best outcome if we can pull it off. Augmented repair technique, we try to do a repair with scaffolding, with various injectables, PRP, stem cell, et cetera. And then if you're not a candidate for these things, then we're gonna go to the tried and true reconstruction. And I'm not here to tell you there's anything wrong with an ACL reconstruction. I do them all the time. I do far more of those than I do bears and ACL repairs. A reconstruction is an excellent, excellent surgery. We're just looking for newer options. There are many ways to place your femur and tibial tunnels. There are many drill options. I used to use what's called an anteromedial portal, where you would drill from outside the knee across the knee, and your pin would come right out the lateral thigh, and that's where you placed your graft. Now I drill outside in with a special device that allows me to pinpoint the location of the tunnel. But again, there's not one technique that's better or worse than the other. It's what the surgeon typically prefers. This that I'm showing you here is called an all-inside technique with buttons that are placed on the femur and tibia. Those are one-way buttons. They allow you to tension the graft appropriately. There's a way to do that too, so that you don't under tension the graft. But this is an ACL reconstruction, okay? So this graft has either been taken from the patient or taken from the freezer, prepared as an ACL, femoral, tibial tunnels placed, okay? These are those biologic factors that I mentioned that the body's trying to do at the time of the ACL tear. The biologic augments that are available now, platelet-rich plasma, is taking your own blood, spinning it down and taking the high platelet concentrate and giving it back to the site of injury in the hopes that it helps to augment repair. There are growth factor supplements. Stem cell therapy is its own presentation. Mesenchymal stem cells are pluripotential stem cells. In other words, stem cells that could turn into anything, for better or worse. But there is a role for them. I do not use stem cells in my practice, but certainly there are centers that are working and experimenting with that. And then there are bioscaffolds and growth factors. The collagen implant for the bear is a bovine-derived implant. I'm going to show you a picture from an intraoperative photo. And consider it a scaffold, okay, where we soak it with the patient's own blood, put it into the defect, and then it's held in place with a couple of traversing sutures that become an internal brace. And what that does is provide all of these growth factors and healing factors that can't do their job in the setting of that synovial fluid. So we're helping it along, if you will, by taking your own blood in surgery, soaking this implant with it, putting it up into that defect, and closing you up, okay? And the outcomes have been pretty spectacular. So when we're trying to figure out suitable candidates for an ACL restoration or bear procedure, as I've said, tear location is everything. We can usually determine that on the MRI, but not always. Depending on the tear pattern, sometimes you can see that clearly you have plenty of stump. Sometimes you can't, which is why we usually consent patients for both if they meet other criteria for a bear. Tissue quality is something that you can try to determine from the MRI, but typically that's an aha moment in surgery. The timing of surgery, the sooner the better. It says 4 to 6 weeks here. That's been traditional. Now they're putting out to 3 months or more with good results. And again, younger patients have better healing potential. Non-smokers, people without diabetes, all these other factors play a role in how well you may do. And the literature currently suggests that 30 to 40% of all ACL tears may be amenable to a bear procedure. However, that is just the tear specifically. That's not taking patient factors into account. Okay, that's just the tear location, the tear pattern. 30 to 40% of them estimated would be good candidates for a restoration procedure. I mentioned the internal bracing. That is something that's done at the time of the bear. It is a high tensile suture traversing the femur to the tibia, lies adjacent to the repaired ACL, and provides a framework that the bear implant actually rests on so it doesn't float around the knee. The suture actually traverses the bear implant to keep it in place. So the bear is considered a biologic scaffold, okay? And what it does is help to create a biologic bridge, hence its name, soaked with your own blood. So what we do when we place the implant is we actually turn off all the inflow of water, the scope comes out, and we never go back into the knee. We put the implant into the intercondylar notch right up against the femur. We pull the sutures distally out the tibia. We fixate them distally in the tibia with either screw or any kind of anchor you prefer, and we're done. We don't go back in the knee because you don't want to wash out those factors that you just put into the joint. And again, the growth factors aren't coming from us spinning down a coat or doing anything on a centrifuge or anything cute, not adding anything. We're literally just taking your own blood, helping your body do its job that it wants to do, soaking the implant, putting it in the knee, and being done. Now, obviously, I'm oversimplifying that. There's a significant postoperative protocol and rehab protocol that I'm going to mention on here that goes with the bear that is unique from an ACL reconstruction. I mentioned these things, so I'll just put them up. Platelet-rich plasma, again, drawing off your own blood, putting it in a centrifuge and giving it back to you. You may have experienced this. There are offices that can do this, have the capability of doing this. It's used for a wide variety of orthopedic issues, tendonitis, various other issues. Bone marrow aspirate is used, either from the hip, or you can actually take it. You can actually take fat cells as well from the lower abdomen, and that can be drawn off. And those stem cells can be used to promote healing in various tissue injuries. And then the collagen scaffolds. The bear lives in category 3. It is a collagen scaffold. It is a bovine-derived acellular collagen scaffold. So people ask things like, is there a risk of an issue with graft host? Can my body reject it? And that's a great question. But keep in mind, it is not a graft, okay? So the Bear is an implant, and the FDA actually has specific definitions for these terms. It is not a graft, it's an implant, and there is a very low chance of having a reaction to it because it's acellular. So there's no cellular material in that implant. It is purely a tube, if you will, of collagen. So again, we identify the tear pattern on MRI. We place the suture intraoperatively. If it holds, you might be a candidate. If it doesn't, we're going on to a reconstruction. We implant the scaffold, and the biological enhancement is your own peripheral blood that I have anesthesia draw off when I'm doing the surgery. Again, showing you that the best kind of tear is a tear that tears right from the femur. Okay, and that's the majority of tear patterns, so that's good news for all of us, because then I have all this tissue to place suture through to bring it up to the femur, okay? Mid-substance we can work with, that's also a candidate. This is not a candidate. So if the MRI shows that you're torn off the tibia, or I go in there and there's a little wisp of tissue down there, there's nothing I can grab suture with, you can't get the Bear, you have to go to a reconstruction. This is a lot of repeating the same stuff, but again, autologous whole blood, so patient's own blood, not spun down, just taking whole blood, peripheral blood, and we soak the implant that I'm going to show you with it, let it start to get soft, and then place it into the knee before it clots. It's going to develop a large fibrin clot, and that's going to start the healing cascade that would have happened on its own had it not been for the synovial fluid around the ligament. That clot helps to resist the synovial enzyme degradation that would occur in your normal body response without it. And by 8 weeks, that Bear implant is gone, okay? It is resorbed. And what you're left with is the body's own healing tissue, okay? And you can see here, this is how it was originally described. Buttons on both sides. There's the implant with the internal brace traversing it. The implant has been pushed up to the top right there, okay? So you can see that the ACL is dunked, if you will, into the implant. We talked about the benefits of preserving the native ACL. Retained proprioception is probably the biggest issue because you can't get that with a graft. You're maintaining the original attachment sites. Faster recovery is one that I take a little umbrage with. I wouldn't call it a faster recovery. I think the recoveries are comparable to one another, to be honest. But certainly it appears to be a more complete recovery, so that at the end of the year, those who have undergone a Bear feel that their knee is more at its pre-injury state, let's say, than a reconstruction. Not universally, but very often that's the case. And this is the data, okay? And so this is an interesting slide because you can see that this thing stacks up pretty well. This is return to sport rate, patient satisfaction, knee stability testing, proprioceptive scores, and there are objective ways to measure that, and then re-injury rate. And you can see that the Bear procedure is this sort of purplish blue bar here. And so far, it has done very well. And again, this is new to our area, but it's not new to the world. This has been out for a few years now. And you can see that the return to sport rate with Bear is comparable to the traditional repair and reconstruction techniques that we've been using right along. And that it's actually, the patient satisfaction is slightly better. And again, that with standard deviation, I don't know if this is statistically significant, but you get the idea. And here, it is only slightly less than the knee stability scores for a standard reconstruction within 2 points. And proprioceptive scores, it's markedly better. And this is interesting too, the re-injury rate. So across the board, you'll notice something here. Re-injury is not all that common with any of these techniques, right? But it seems to be the least, at least in this data, for the Bear vice the traditional repair or reconstruction. So the recovery timeline, repair versus reconstruction, again, without beating this too severely. The first couple weeks, there's not a lot of motion. For the Bear, the first 24 hours, the knee is usually kept straight. Then they start progressive range of motion thereafter, and it's graduated. It's usually 0 to 40 or 50 degrees, 45 degrees actually, and then it goes 45 to 90 degrees. They are in a brace for the first 6 weeks, and then thereafter they're put in a separate kind of brace called a functional knee brace. But suffice to say, you're looking at a 6 to 9 month recovery with both of these interventions. And I won't go through too much of the details of this, but it is a phased recovery. Just like a reconstruction, there's a phased protocol for somebody returning to living, returning to work, returning to sport, and returning to performance. And it's very well delineated. And when we do bear on patients, since it is so new in the area, we don't just send them to PT and hope for the best. We're actually giving them a large booklet, 2 booklets in fact, in a folder for them that explains exactly what we want for them, so that there's very little variability in their post-operative course. So we have to consider surgical graft integration, strengthening, scar tissue management, and functional progression. And then phase 3 to 4, they have more progressive strength training, sport-specific drills, and we put people through a functional assessment or a sport-specific functional assessment return to play criteria, depending on the sport, and that's how we get people back. I just wanted to include a couple slides here because I think it's an important topic. ACL tear prevention is a huge topic. It's big in high school and colleges across the nation. I always tell people this at conferences: there's no true way to prevent ACL tear 100%. And if you live on a couch, you probably can, but otherwise, if you're up and doing stuff and living life and living in an uneven world, even if you're not an athlete, there's a chance you can buckle your knee and get an ACL tear. The idea of these programs is that they can help to decrease the risk of ACL tear. And again, our target audience is typically the female athlete because they have the greatest burden for this injury. And so a lot of these schools, high schools and colleges, have developed various programs or have purchased previously established programs for their athletes. And PEP is one, Perform Plus, the 11 Plus. And so these are all different programs that focus on core strengthening, appropriate landing, pelvic mechanics, and all these things to try to decrease the risk of ACL. Because we think that all of these things, the way an athlete lands when he or she pivots through the knee, the way they come down from a rebound, the way they kick the soccer ball, the way they plant their contralateral foot, all these things probably play a role in the ACL tear, and these programs aim to address those, and core strength is hugely important. And then bracing. This comes up all the time in my world, and it has for decades. Are there braces that can prevent ACL tear? The short answer is no. There are a lot of braces that are marketed to the community and even to the medical community as well that are very expensive, that even come with guarantees. If you tear your ACL when you're wearing this brace, we'll buy it back from you, kind of thing. And that's great. But the reality is that the literature, the research has not really teased out which braces can help, or if any brace is effective in preventing ACL tear. So we don't routinely recommend ACL bracing to prevent an ACL tear, However, when we reconstruct an ACL or we do a bear or any other ACL surgery, most of us do put you in a brace thereafter, and that's usually to restrict motion, okay? And then a lot of us, myself included, will put you in a functional sport brace after you've had surgery on your ACL in the hopes that it's preventing a repeat injury to the graft or the repaired ACL. So again, that's the distinct difference. A healthy knee without a history of an ACL tear, putting on a brace to prevent an ACL injury, the research doesn't show that helps too much, okay? It does for MCL on certain positions in football, but not for the ACL. The research for bracing a post-surgical ACL is different. That research is also varied. Nobody agrees on whether or not that's helpful or, in fact, harmful. So I tell you all this to tell you that, if and when you ever blow your ACL, and I hope nobody in this room does, understand that as the patient consumer, when you go to a surgeon, you are buying his or her expertise and opinion. And you're buying their knowledge and what has worked best for them based on how they trained, what they read, and what works in their hands, okay? And so there is so much controversy on so many things in all of medicine that you'd get queasy if I told you all things. There are very few raw, straight facts that we all agree on in terms of surgical intervention for things like this. So certainly medicine and healthcare has its facts. ACL reconstruction and post-op rehab is not one of them. So again, immediate post-operative bracing depends on what you believe and where you trained. I do brace people post-operatively for a period of time. I do not brace people prophylactically in the absence of injury. Functional bracing and return to sport, the Bear people, the research out of Boston Children's Hospital does recommend sport bracing and functional bracing, and I do that on all my Bears. I give ACL reconstructions the option. I usually release them to sport between 6 to 9 months, depending on their functional return, and I will have a conversation with them, just what I told you, that the research is all over the board. I've traditionally given patients the option. I let them decide. These braces aren't cheap. A lot of insurances don't cover them, and I let the athlete decide. I give them what I know. So a couple of case reports, and then we're going to be done here. The first one was a 35-year-old female, status post-twisting injury from a trip and fall through her left knee, BMI of 38, sedentary smoker. A month after the injury is when I first met her. Immediate pain, significant swelling following the injury to the knee. She continues to have ongoing subjective instability, so when she's walking, she feels like it's giving out. The MRI, I don't have, unfortunately, but it did demonstrate a complete ACL tear with an intact tibial stump. So I'm thinking she could be a Bear candidate, although not perfect because there's some other stuff that gives you a little bit of pause. So repair or reconstruct. So for her, actually, let me pause for a second. The bridge-enhanced ACL restoration, the Bear, and you'll see bridge-enhanced ACL repair, which it's used interchangeably, but it's actually written the way they've designed it. It's bridge-enhanced ACL restoration. We utilize that collagen scaffold like I talked about, preserve the native ACL, provide the proprioception, but it does require adequate ACL tissue in order to perform it. And the traditional ACL reconstruction, we have to remove all that remaining tissue that's in there in order to perform the job. So this patient, let's talk about age and activity level. She's sedentary, she's young at 35, she's a non-athlete. Rehab compliance was not felt to be an issue. I thought she would do okay with that. The timing since injury, she was a candidate in terms of timing alone. Her tear pattern and location, she did have enough of a tibial stump. So when I went in, these are intraoperative photos. I apologize, they're not really reproducing all that well in here, but when I first went in, the anterior cruciate ligament already had a significant degree of fatty change. This yellow is fat, okay? And it should look more like a pearly white, even injured tissue. And even after I freed it, it didn't look all that great, okay? And this is a device that actually passes suture through the tissue. So I placed suture through the tissue, placed an anchor up high, and it tore out. And so the body usually makes the decision for the surgeon, and it did in this case, and that, okay, well, I couldn't restore that, so I had to take everything out and give her a standard ACL reconstruction with her own quadriceps. So case 2 is a 47-year-old male, a little larger, a 41 BMI, former smoker, 2 months following his injury, immediate pain, significant swelling following a twisting injury through the knee, ongoing subjective instability, high-grade interstitial change within the mid-substance to the proximal 2/3 of the ACL. He had that classic bone bruise pattern that I showed you. And again, repair or reconstruct for him. And there's his actual his MRI. So you can see that it looks like an avulsion from the femur, which is good news for the Bear, but he has significant interstitial changes here as well, and there's thickening through the ACL, which could signify injury distal to that site. And then he has that bone bruise pattern that I mentioned, the posterior third of the tibia and the mid-third of the lateral femur. So we brought him to surgery. Unfortunately, he was a Bear, right? And so this is the ACL stump. I debrided the stump. This is the PCL sitting in the background there. Bring the tissue up, and that's the pearly ACL tissue that I'm talking about, okay? That's a little bit of the ligamentum mucosum still attached distally there to the tibia. We passed sutures. It held. I was able to pull it back, and that is an ACL that has been reattached to the femur. This one was done with what's called an interfix screw or biocomposite screw. And this is the internal brace that's traversing down the side of that graft. This will be fixed onto the tibia once the Bear is placed on there. Now, I can't show you an intraoperative photo of what the Bear looks like because, like I said, when we put it in, we have to remove all our instrumentation lest we wash out the Bear. Okay, so this is what it looks like just before I put the implant in there. And here's the implant. So that is literally all I'm talking about. It is a white piece of collagen. And these sutures traversing it are going from this is going from the femur that I just showed you. This is coming through. We use a needle to traverse the tissue, the collagen, and then this is going back into the knee, going down through a tibial tunnel, and this is hiding. The tibial tunnel comes down here where we're going to fix it. And so we soak this with 20 milliliters of your own blood, and when it's torpedoed or looks like a bullet, we put it into this arthrotomy, this incision we've made in the capsule, right up into the notch where it belongs, and then this suture gets pulled down and fixed down here on the tibia. And that's how you finish a bear. So the bottom line for the presentation is this, is that the bear is wonderful, it's exciting, it's great, we're getting great results. I'm happy we're doing it now at LECOM, but it's not for everybody. We've had people call, I had a patient call from Canada who wanted to come down, pay cash, get it done, they're not doing it up there. But after I interviewed her on the phone, I realized she wasn't a good candidate, you know, and she wasn't real happy with that, but I had to explain to her that she didn't meet a lot of this criteria. Her injury was too far out. There were some other factors. So it's ACL care in 2025 America is very personalized, as it should be. It's very patient specific, and there's not one good answer for every patient. Okay, so this is amazing technology. It continues to grow, it continues to get better. We're getting better at the techniques and at the various interventions. We're getting better with the chemistry and the biologics. But it starts with the patient. It starts with the injury, the patient factors, the type of tear for the best outcome. And that's all I've got. Any questions?
I thank you all. Have a good time.